Hi, everyone. This is Mohammed Bitar. I'm an assistant professor of medicine at the University of Tennessee Health Science Center in Memphis and a member of the Education Committee of Spartan. On behalf of the Spondyloarthritis Research and Treatment Network, also known as Spartan, the Assessment of Spondyloarthritis International Society, also known as ASAS, and the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, also known as GRAPPA, I would like to welcome you to our 2021 Post-ACR Symposium on Spondyloarthritis. This symposium is a joint Spartan ASAS GRAPPA continuing medical education activity. Research on spondyloarthritis has been steadily advancing over the past decade. Today, we present to you internationally renowned experts in the field of spondyloarthritis, who will discuss different important topics, including year-in reviews, sex disparities, and new radiology concepts. We encourage you to type your questions in the chat box, and our experts will be online to respond to your questions. In order to receive CME credit for attending this educational activity, please complete the survey that will appear in the chat box. I will be co-moderating this symposium with my colleague and Spartan Education Committee member, Dr. Soha Dolat Abbvie. And now I will hand it over to Dr. Soha, who will introduce our first speaker.
Thank you, Dr. Peter. Hello, everyone. My name is Soha Dolat Abbvie. I'm a rheumatologist in solo practice in Los Angeles, California, and assistant clinical professor at UCLA Geffen School of Medicine. I'm a member of the Education Committee of Spartan, and I'm honored on behalf of Spartan Grappa and ASAS to introduce our first speaker, Dr. Abbvie, who is going to give us the talk on year-in review in psoriatic arthritis. Dr. Abbvie is Associate Professor of Medicine and Epidemiology in the Perelman School of Medicine. She's also Deputy Director of the Center for Clinical Epidemiology and Biostatistics and Director of the Penn Psoriatic Arthritis and Spondyloarthritis Program. Dr. Abbvie's research program focuses on pharmacoepidemiology and observational studies of psoriatic arthritis. The mission of her research program is to improve outcomes in psoriatic arthritis by accelerating diagnosis, increasing the focus on meaningful patient-centered outcomes, and developing and advancing methods for precision medicine. Her recent work has focused on pragmatic trial design in psoriatic arthritis and also on the early identification of psoriatic arthritis through better understanding of predictors of disease that can be implemented in the electronic medical record and design of a trial to test prevention of psoriatic arthritis through treatment of psoriasis. And now I will ask you to please join me in welcoming Dr. Abbvie to start her presentation.
Hi, my name is Alexis Abbvie. I'm going to be giving a year-in review for psoriatic arthritis. This is a tough job anytime because there's a lot to summarize for 1 year. It's also hard to define like what is the last year. So I've taken some things from 2020 and then you see a lot of e-published stuff from 2021. So here we go. These are my disclosures. And by the way, I put the headlines thing on the previous slide because I'm really going to just be talking about headlines as I get through all these different studies. So first I'm going to talk about some new randomized controlled trials or randomized clinical trials that have been published in the last year or so, or presented in the last year. So the first one is a series of interleukin-23 inhibitors. So this is the last year to 18 months has really been about the year of the IL-23 inhibitors. Guselkumab presented 2 studies or published 2 studies in the Lancet this past year in 2020. They were this Discover 1 and Discover 2 trials. So I think we've seen these a number of times since then. But just because they published in the 2020, even though they presented in 2019, I did put it here. So here you see in the ACR 20 responses for Discover 1 and Discover 2. So they have the 2 arms here, Q8 weeks and Q4 weeks compared to placebo in both trials. Discover 1 had more of the patients who were previously biologic exposed. And you can see that in Discover 2, where patients were treatment naive, you can see that every 8 weeks and every 4 weeks really lays on top of each other. In Discover 1, they did separate a little bit, and there were some numerical differences where patients in the Q4 arm did a little bit better than patients in the Q8 arm, but very tiny amount. And that was numerically different, but not statistically significantly different in patients who were TNF exposed. The Cosmos trial was also published or presented recently, not yet published, I believe, and that examined the Q8 dose in just patients who were TNF inadequate responders. And they found that it worked similarly to what we see here. That trial did not have the Q4 dose. So beyond guselkumab, another IL-12/23 had a publication this past year. This is tildrakizumab for psoriatic arthritis. This is the 52-week phase 3B study. So this is just finally published for the 52-week endpoint here. And we see something similar to what we've seen in guselkumab. And here you see, actually, interestingly, all the doses behave very similarly, which was kind of perplexing about this particular trial. So phase 3 trial coming soon. All right, so now we have the risankizumab data in the phase 3 studies. This was presented last year at EULAR. It has not yet been published. So the keepsake trials were number 1, CSD-MARD inadequate responders, and number 2, biologic inadequate responders. So they had 2 separate trials. And in the in the keepsake one, risankizumab ACR20 response rate was 57% compared to 33% in placebo. And then in keepsake 2, it was 51% compared to 27%. So we see statistically significant differences in response rates between risankizumab and placebo. So this adds the third IL-12/23 P19 subunit inhibitor to the armamentarium for potential psoriatic arthritis treatments. Of course, guselkumab is the only one that is approved so far for psoriatic arthritis. All 3 are approved and used for psoriasis. Now, one more therapy, again, not so new, but published in the last year or so, is the bimekizumab phase 2B trial. This is the 48-week endpoint data. This is the ACR50 response, so that was a unique higher endpoint for this particular phase 2 study. And we saw that bimekizumab works and is now in phase 3 studies, and we're waiting that data, which will probably be a couple years, maybe a year or 2 down the road still. So as a reminder, bimekizumab is different than secukinumab and ixekizumab in that it is an IL-17A and F inhibitor, whereas secukinumab and ixekizumab are IL-17A inhibitors only. So more to come, hopefully in the next year or so. All right, so those first trials were those kind of run-of-the-mill designs that everybody uses to get FDA approval. Now we're going to talk about some more interesting trials that actually have different types of clinically relevant endpoints. So this is withdrawal of ixekizumab in patients with psoriatic arthritis. So in this particular study, patients were on ixekizumab every 2 weeks. So again, in the US, it's the every 4-week dose is approved, but this was prior to the labeling. And so they used a Q2-week dose. So patients were on that dose until they reached minimal disease activity. And then at a certain time point, they were randomized to be withdrawn or to continue on ixekizumab Q2 weeks. And I put this in the wrong corner here, but this is when they were randomized to be withdrawn. And then you see that patients who were withdrawn kind of start to flare over time here. They lose their MDA response. And these patients who were maintained also start to lose some response, but actually maintain relatively well. So then the interesting question is always, okay, we kind of know that if you're taking a therapy away from a patient with potentially active disease, and then you're bound to see some rebound of the disease. So what happens then when you restart the therapy? So that's this upper one right here. So after flare, they restarted the therapy. They even restarted the therapy in people in this placebo group who were not withdrawn. And everybody gets better. So that's kind of nice to know. So even if you drop off a little bit, you do respond pretty quickly and pretty well after restarting therapy. So that's good news. So an interesting design, kind of learn something here. And in fact, also learn something maybe about the placebo group there, which is kind of interesting. All right. Next trial was published in JAMA, and this is not PSA specific, although you'll see that there was a subgroup of patients with psoriatic arthritis here. There are 20 patients in one arm and 22 in the other. So a group of patients with psoriatic arthritis in this particular trial. Now, the overall goal of this trial was to determine whether therapeutic drug monitoring versus standard drug monitoring for infliximab helped improve outcomes for patients with a variety of immune-mediated inflammatory diseases. So we already know that GI doctors do this all the time, but in rheumatology, we tend not to use this strategy very often. So they had a very protocolized way of managing this. And so overall, actually, there was no significant benefit to therapeutic drug monitoring compared to standard clinical care. And this was actually particularly true in psoriatic arthritis, which the kind of delta really favored, beta coefficient really favored standard therapy. Obviously, it touches that line there, so not statistically significant for any one of these individual diseases, but just generally to look at the difference. So is there a role for therapeutic drug monitoring in psoriatic arthritis? Not really clear that there is, even in Crohn's or ulcerative colitis, interestingly. All right, next one is fecal transplant. I don't know about you, but this doesn't sound all that interesting to me to have as a patient of fecal transplant, but a number of patients actually ask about this. There's a lot of interest in the microbiome, and can you give a fecal transplant to kind of reset the microbiome? Well, that was the question that was to be addressed in this particular randomized control trial. So it was an exploratory trial over 26 weeks, or 24 weeks, I believe is the primary endpoint. They looked at whether patients who were randomized to fecal transplant compared to sham fecal transplant, I actually don't know exactly what that looks like, whether or not they did better in terms of disease activity, but also in terms of time to biologic therapy. So the kind of failure was needing to start a biologic DMARD. So what you see here is that patients who got fecal transplants actually did worse over time and were more likely to need a biologic therapy. And this is just another way of looking at this, that patients who were received a fecal transplant had higher HAC-DIs over time compared to the sham treatment. So not only did it not work, the conclusion of the abstract is that overall FMT appears to be inferior to sham in treating patients with active PSA. So not a great treatment. Speaking of alternative treatments, one of the things that a lot of patients ask about is cannabinoid treatments, THC or CBD. So in this particular study, they looked at synthetic CBD in patients with psoriatic arthritis and osteoarthritis of the hand. And pain was really the main outcome. So among those two different groups, pain at 12 weeks. And if my camera wasn't in the way, you could see that all the p-values are not statistically significant. So basically, when you looked at pain in the last 24 hours at 12 weeks compared to baseline, there was no statistically significant difference for CBD. Not that it doesn't help some people for some things, but it didn't seem to be a significant benefit for pain. That's being presented this year at the ACR, by the way. Next, some other not trials, but real-world evidence that that help inform treatment. So this is a large study in Europe, the PSA Bio study, in which they were not randomizing, but following patients who were initiating ustekinumab or a TNF inhibitor over time. And they're following these in parallel with same assessments. And the goal is to really determine, what does this look like in clinical practice? Well, patients who were initiated on ustekinumab, this is the first bar here, versus a TNF inhibitor. So ustekinumab TNF inhibitor for a variety of different outcomes, CDAPSA remission and CDAPSA LDA being a couple of those, VLDA, MDA. So you can see that TNF inhibitors did slightly better than ustekinumab, but really overall the same. And then if you looked at, so those are just first line, if you looked at second line and third line, you see similar trends, but really overall TNF inhibitors and ustekinumab were relatively similar in terms of clinical outcomes in this real world study. So that's interesting and maybe not exactly what we would have expected from clinical trial data. All right, last one of the clinical trial section. So in January 2021, that date I have circled up there, Pfizer released results for the 1133 study in which they compared tofacitinib to TNF inhibitors for MACE and for malignancy outcomes. And they did not, tofacitinib was not inferior. So there was a difference between the two arms. So we still haven't seen that data yet. But what we do have is this other study that's from RMD Open, recently published on adverse events of special interest, including those same events across different diseases. And here, what I'm just pointing out are the MACE events, lymphoma, and malignancies, which we were told about in that press release and the tiny little table we have without other data. And what we see is that you have similar incidence of those different outcomes in RA and PSA. I think what would be interesting is to know if this was age and sex adjusted. or adjusted for other comorbidities. This is not. This is just pure data. So I think that these will be things that we'll be looking forward to in the next few months. So looking forward to that paper. All right, actually, this is the last one of the clinical trial section. And I just put this in there. This is a recently published paper within the Journal of American Academy of Dermatology about racial disparities in clinical trials for psoriatic arthritis. And the main thing I wanted to point out here is that only 0.4%, 30 patients of over 6,000 patients were Black. So we know almost nothing in these clinical trials about patients who are non-white. 80% of patients are white in these trials. So this is something that we need to do better with. In this particular paper, they give us lots of ideas about how to increase representation within our clinical trials. So just one other way in which clinical trials really don't reflect our patient population, but this is generally true across research and something we need to do better at. All right, comorbidities and extra-articular disease. All right, so some of the things that we've talked about a lot are metabolic disease in psoriatic arthritis and psoriatic disease more broadly. We know that apremilast is associated with this side effect of weight loss. So a lot of our patients want that particular side effect. In this particular study, Lynn Ferguson et al. Examined different metabolic parameters and how they changed over the course of 6 months of therapy with apremilast. So first here we see weight. There were some reductions in weight on apremilast, and this is also seen in BMI as well as waist circumference, and a little bit in the hips, not as much in the hips. They also then looked at a variety of different aspects of the total abdominal fat, for example, liver fat and other things, and show that there are some additional features of body composition that actually did improve on apremilast, even though the average weight reduction was relatively small. So this is kind of interesting and raises some more questions that we might want to look into more in terms of both apremilast, but also some of our other therapies. Adverse cardiovascular events, we are known to be increased in psoriatic arthritis. In this particular study, they wanted to know whether or not they're increased by different types of therapy. So they took patients who were initiating TNF inhibitors, ustekinumab, IL-17 inhibitors, and apremilast, and they looked at the hazard ratios for cardiovascular events. After adjustment for some factors, they actually, not adjustment, but weighting for some factors when they created a propensity score. So it's hard to tell exactly how much confounding by indication there is here, so we just take it for a grain of salt. This is just as observed. But what they observed was that ustekinumab had twice the rate of major adverse cardiovascular events as TNF inhibitors, IL-17 inhibitors, somewhere around that same mark. And then apremilast was elevated, but basically the confidence interval was wide around TNF inhibitors, so no significant difference there. Why is this? We do think that TNF inhibitors have a benefit in terms of improving cardiovascular events. That's our thought. A lot still to figure out there and not really well demonstrated yet. But this kind of maybe suggests something similar. So taking this with a grain of salt, but an interesting study to think about. All right, and then next along the lines of cardiovascular events, are there markers we can use to predict? We already know that some of our markers of, so Framingham score, for example, doesn't perform all that well in terms of predicting risk for myocardial infarction in psoriatic arthritis. That's why EULAR came up with that 1.5 multiplier. So the goal here was to see, are there other biomarkers that can help us give more information about these different cardiovascular events? And so they found that there were some of these different biomarkers. Actually, if you look at all of these different biomarkers they examined, several kind of pop out a little bit, although you can see that some touch the line of not significantly different in patients who had a cardiovascular event versus did not have a cardiovascular event. There's this glycoprotein A, or glyc-A, that does seem to be one of the ones related to increased risk for cardiovascular events, as is the apolipoproteins, some of the apolipoproteins. So they found that adding these to the model with Framingham risk score didn't significantly improve the predictive ability of Framingham risk score, but I'm sure they're going to keep working on this and think about some other combinations that might help. So getting closer there and learning more about how we might predict who is at risk for cardiovascular events. Okay, now we're going to shift from cardiovascular disease to inflammatory bowel disease, a related condition. So we know that interleukin-17 inhibitors are associated with IBD, at least in clinical trials, but there's been a lot of debate about whether or not that's truly because of the drug or because of the patient's underlying risk. We're seeing that risk, and then we're much more cognizant of it. So in this particular study, they took new initiators of IL-17 inhibitors, new initiators of etanercept, and new initiators of apremilast, and they examined the relative risk for IBD in these patients. What they found is that patients who were initiating an IL-17 inhibitor had essentially the same risk as patients initiating etanercept. There was no significant difference. On the other hand, there was a higher risk for IBD among IL-17 inhibitors compared to apremilast, which is kind of interesting. So I think there's something more to understand there about that, the mechanisms by which apremilast may be lower or why they're so different. But something interesting that's newly published. All right, this study was also published, and then it was also presented in the last year and a half or so at one of the ACR meeting, ACR EULAR. Now I'm forgetting which one. So this was recently published though in arthritis and rheumatism, and is the risk for hospitalized serious infection after initiating ustekinumab compared to other biologics. So they were interested in whether or not there were significant differences, and they looked at two different data sets, MarketScan and Optum, and then they combined them using a meta-analysis technique. And what they found is that overall, it seemed that ustekinumab resulted in a lower infection risk than any of the other biologic therapies tested here, including apremilast. So it's a little perplexing why we always think of apremilast being lower infection. Maybe we're wrong. So there's some things that we need to kind of further sort out here, but this does kind of generate some new hypotheses to test. All right, next on to epidemiology, diagnosis, and biomarkers, or the last section, and everything combined. So first of all, epidemiology. So there was a nice study from Mayo, Paris Karmacharia, in which he examined the epidemiology of psoriatic arthritis over time. And this was to understand whether or not PSA is increasing or decreasing in terms of incidence. And what we see here is that overall, the incidence is relatively similar. There were some interesting spikes among females that's not quite well understood, but if you kind of look at these nice curves, it really looks fairly stable over time, which is kind of interesting. All right, next, our group examined some risk factors for psoriatic arthritis. And one of the studies that was recently published was looking at body surface area and the association with PSA. And we know that body surface area of psoriasis is closely linked to obesity. So we wanted to know whether those two things were independent. And in fact, more severe psoriasis is associated with a higher risk for psoriatic arthritis over time, in particular over the next 4 to 5 years, which is what we examined here. And there's also an additive contribution of obesity. What I'm showing this figure here is the interaction between the two. And you see that having severe psoriasis and obesity gives you a significantly higher risk, but it's not quite a statistically significant interaction term. So they both provide some risk, and together probably worse. All right, so the next question that has come up a lot over time, but we've seen a lot of papers of interest about in the last 2 years or so, is whether or not treating psoriasis improves outcomes for patients with psoriatic arthritis. So in this particular study, there's 3 studies recently published, all EPUB, 2 in ARD and 1 in arthritis and rheumatism. And all 3 of these studies were within single center cohorts, and they found that biologics were associated with reduced likelihood of developing psoriatic arthritis. All 3 studies were actually designed fairly similarly. On the other hand, we recently published a study showing that, suggesting that biologics were associated with an increased risk for developing psoriatic arthritis. Now, it's probably not that it's a true increased risk, but more so that there's some confounding by indication. In fact, if you look carefully, you'll see that a lot of PSA diagnoses happen right after the biologic is prescribed. So this is across the United States, and it's not within a cohort, so we don't have great diagnosis data. And so if you see a biologic prescribed, probably because they suspect the patient has psoriatic arthritis, then you get the psoriatic arthritis diagnosis later, it inflates the hazard ratios. Another study by Joe Marola et al. Published in the Journal of American Academy of Dermatology basically shows the same thing. So 3 studies suggesting biologics are protective, 2 studies suggesting that maybe not so fast. So I think this suggests that prospective studies are needed, and I'm excited to know to tell you that a lot of these studies are getting going, so we'll be hopefully seeing results in the next few years. Last couple points here. So one is the role for ultrasound. So we know that fibromyalgia is really difficult to separate from PSA, especially in those patients that have both fibro and PSA. We've seen in a number of abstracts that these patients have higher patient-reported outcomes. So this study examined whether or not you could use ultrasound to distinguish between the two. And ultrasound does show the inflammation when present, and you can see the dissociation between the level of inflammation present and the patient-reported outcomes in that group with PSA and fibro. So this kind of shows an additional role for ultrasound in this group. Biomarker studies. So there's been a long goal of developing biomarkers for PSA, and we don't have any yet. But this study examines serum protein biomarker panels and the ability to distinguish early arthritis patients who have RA from those with PSA. And here what you see is that RA in the red and PSA in the green bar here, these patients do look different in terms of these biomarker panels, and they seem to separate out relatively well if you look at this principal component analysis. So lots more to come here as well, but this is promising that there's something on the horizon that will help us with diagnosis. Okay, finishing up with a couple of patient-directed ones. So this was an interesting study published by Laura Coates. So this is still EPUB, not quite fully published yet. And what they did is they wanted to know whether or not there are certain aspects of patients that influence their idea of remission. And so if you look at some of the patient-reported outcomes here, you can see that some of these are directly related to achieving remission and the patient's report of being in remission. And some of these things include comorbidities, for example. Having more comorbidities, you're less likely, having higher pain scores is indirectly associated with remission, whereas some of the comorbidities were actually associated. And then physician global assessment in the LDA stayed in that model. So this kind of is somewhat intuitive that some patients that have more catastrophic pain sensing may be less likely to get to remission or perceive themselves in remission. So that kind of, again, underscores the importance of understanding how much fibromyalgia or central sensitization is going on so you can identify those patients and treat them separately. And then finally, this is just a more general inflammatory arthritis abstract. The EULAR put out recommendations for implementation of self-management strategies in patients with psoriatic arthritis. And speaking of the last abstract, when we're talking about getting to remission, it's not only the therapy, it's the self-management strategies. So this is a really nice paper to help clinicians to kind of promote self-management for patients. So something to take a look at and read in more detail, but just wanted to point this out. All right, that was a rapid fire tour of all the headlines for the past year. So let me just quickly summarize by saying new therapies are here and they're coming. So we have more on the horizon. We learned a lot about our existing therapies, but we have a lot more to learn. So I think some of these studies raised as many questions as they answered. Prediction and prevention of PSA is moving. We got a lot of ground covered in the last year or two here. Diagnostic tests are on the horizon, and I think some of the protein biomarker stuff is really interesting. Separating fibro components from active PSA is really challenging, and I think we're starting to get more people thinking about that challenge. And finally, self-management and addressing patient-important outcomes is really of great importance. And I think that importance is increasing as we understand more and more about how to best treat patients and how important it is to partner with patients in treating them effectively. Thanks so much for going on this tour with me, and look forward to discussing any questions.
Thank you very much, Dr. Abbvie, for your excellent presentation on psoriatic arthritis review. I'm honored to introduce Dr. Wang, who is going to give us a very informative update on year in review in axial spondyloarthritis. Dr. Wang is an assistant professor of medicine in the Division of Rheumatology at Columbia University Irving Medical Center. Her clinical and research interests focus on spondyloarthritis, including ankylosing spondylitis and psoriatic arthritis, particularly in epidemiology, outcomes research, and comparative effectiveness research of spondyloarthritis. She was awarded the 2019 SAA Brockle Early Career Investigator Award, recognizing her outstanding contributions to the care and understanding of patients with spondyloarthritis. She finished her medical school at Peking Union Medical College, Beijing, China, her residency in Maimonides Medical Center, Brooklyn, New York, and her fellowship at NIH Clinical Center, Bethesda, Maryland. Please join me in welcoming Dr. Wang to start her presentation.
Good afternoon. My name is Rensheng Wang. I'm a practicing rheumatologist and adjunct assistant professor at Columbia University Irving Medical Center. I will present the year in review for the axial spondyloarthritis. This video was recorded on October 12, 2021, and I have no relevant disclosures. The goal of the review is to identify the most important studies published in the past year and discuss their impact on clinical practice as well as potential directions for future research. A brief summary on the methods for this review. I did a PubMed search for ankylosing spondylitis and axial spondyloarthritis from November 11, 2020, right after last year's ACR meeting, to October 12 this year, the day this video was recorded. I screened the papers by their titles and then abstracts, and eventually came out with these 8 papers. We will start from translational studies and then move on to clinical studies. The first paper I will talk about is polygenic risk score have high diagnostic capacity in ankylosing spondylitis. For the past 40 years, HLA-B27 has been widely used in diagnosing ankylosing spondylitis. However, it is not sensitive or specific as a diagnostic test, and previous studies have shown that it only explains 20% of overall genetic risk of the disease. So what is the polygenic risk score? The polygenic risk score is a number that summarizes the estimated effect of many genetic variants on a given phenotype. And from a statistical point of view, it is a continuous measure as opposed to HLA-B27 is one gene and a dichotomous variant. So using data from GWAS study in more than 15,000 AS and 20,000 controls, the authors developed and validated the genetic risk scores in individuals of European and East Asian ethnicity. On the left side is the receiver operating characteristic curve to show the performance of different predictors. The purple line represents the polygenic risk score, blue line is for HLA-B27 only, green line stands for polygenic risk score without MHC molecules, and the red line represents the performance of previous GWAS significant loci. As you can see, polygenic risk score developed by this study had the highest AUC of 0.924, meaning it is an excellent predictor to differentiate AS versus non-AS. In clinical practice, the utility of a test depends on the prior test probability of the disease. So the author gave a hypothetical scenario where the prior test probability of AS is 30%. It is about the prior test probability of AS in patients younger than 45 years old with chronic back pain, particularly inflammatory back pain. The negative predictive value and positive predictive value of the polygenic risk score and HLA-B27 varies with their population distribution as shown in figure 2. At a low distribution, the negative predictive value of polygenic risk score is almost close to 100% and outperforms HLA-B27. So the take-home message is polygenic risk score can be used to facilitate diagnosing AS in patients with chronic back pain. It is probably a very useful tool to rule out the diagnosis. The next paper is about a potential new treatment target. Although we have different classes of biologics that target inflammation, we do not have any medication that directly target pathologic bone formation in patients with AS. Tennyson C is an extracellular matrix protein upregulated in multiple inflammatory conditions, including lupus, psoriatic arthritis, and ankylosing spondylitis. In this paper, the authors examined whether TNC plays a role in the process of enthesial pathological new bone formation. So first, they showed TNC is upregulated in the ligament tissues from patients with AS and in animal models. They stained TNC and quantified its expression level in the enthesial tissues from patients with AS and compared to the normal controls. And there is a significant higher expression of TNC in the AS tissues. In the inflammatory arthritis model, collagen-induced arthritis, the TNC expression level is also significantly higher than the controls without inflammation. Next, they show that inhibition of TNC suppresses enthesial pathological new bone formation. Using micro-CT, the authors measured the new bone formation in the hind paws of these animals, either treated with antibodies against TNC or treated with placebo. And as you can see, there's significant less bone formation in the antibody-treated group. Similarly, in the collagen arthritis model where the TNC was knocked out, the knockout mice had less bone formation as well. The author also demonstrated that TNC is mainly expressed by FSP1 positive fibroblast, and its function is mediated through Hippo signaling pathway. So the main message from this paper is suppression of TNC could potentially be a therapeutic target to prevent pathologic new bone formation. And hopefully there will be more research coming out along the way. Next, we will switch gear and talk about imaging studies. MRI as an important tool to visualize active inflammation continues to be the focus of many studies. It has been shown that both inflammatory lesions such as bone marrow edema and structural lesions such as fat metaplasia can be seen in the axial skeleton in general population. So the authors conducted a cross-sectional population-based study to identify clinical factors associated with a false positive MRI change in the sacroiliac joint and in spine. And here is the main result. For the SI joint MRI, delivery in the past 12 months, positive HLA-B27, and back pain in the last 3 months were associated with bone marrow edema on the SI joint MRI. Age and the physically demanding work seem to be related to bone marrow edema on spine MRI, but at a much lesser extent. So the take-home message is we should be careful when we interpret MRI results in these scenarios. A positive finding of bone marrow edema could represent a true disease condition, but at other times it could be a false positive finding. What about SI joint or spine MRI findings in patients with peripheral arthritis? The next paper is focused on axial involvement in patients with early peripheral SPA. The authors used data from CRESPAR study, a single-center, double-blind, placebo-controlled trial of TNF inhibitor in patients with very early peripheral SPA, defined as a symptom duration of less than 12 weeks. 56 out of 60 participants had baseline MRI and were included in this study. For comparison purpose, the authors were also included matched patients from B-Giant cohort, a Belgian registry of axial SPA and peripheral SPA. As noted in the demographic table, CRESPR patients were older with shorter disease duration and mainly peripheral arthritis, very low prevalence of inflammatory back pain history. 36% patients in the CRESPR MRI group had a positive sacroiliac joint MRI at baseline, and the sacroiliitis was not associated with back pain. As we can see, there are very low prevalence back pain history. When they examined the SPARC score, the CRESPR median SPARC score was 6, while the B-joint group was 7, and the violin plot showed that they had very similar distribution. Further, after TNF inhibitor treatment, the SI joint SPARC score were significantly decreased in these patients. So these findings suggest that there might be a significant overlap between peripheral and axial SPA. It also raised the question that should we use MRI to screen for subclinical sacroiliitis? Next, we will talk about some clinical trials. The first trial is on the topic of treat to target. In rheumatoid arthritis and psoriatic arthritis, it has been demonstrated that treat to target is an efficacious approach in managing patients with active disease. It was recommended that management of axial SPA should also follow a treat to target approach, although there was no data to support it at that time. So this TICO-SPA trial was the first study evaluating the efficacy of a treat to target and tight control approach in axial SPA compared to Euro study. This is a pragmatic, cluster randomized, open label 1-year trial of patients with active axial SPA not adequately responded to NSAIDs and were biologically naive. 18 centers participated in the trial, and participants were randomized by centers into either a treat to target arm of every 4-week visits with predefined treatment strategy, or Eurocare arm of every 12-week visits at treating rheumatologist's discretion. The main outcome is the percentage of patients with at least a 30% improvement in ASAS health index. A total of 160 patients were included and randomized. The main outcome was met by 47% of patients in the treat to target arm and 36% in the Eurocare arm. Although in favor of treat to target arm, it was not statistically significant. For secondary outcomes, ASAS low disease activity status and ASAS 40 were significantly favoring treat to target arm, but not other not other secondary outcomes. The safety signal were comparable in these two groups. So the take-home message is the treat to target approach was not significantly superior to Eurocare for the primary outcome in this trial. However, the follow-up question is, do we need more similar strategy trials? If so, how can we improve the study design? And how to choose the primary outcomes? And how to appropriately blind the involved parties, including patients and investigators, so that we can get a true measurement of treatment effects. The next trial we will talk about is the COAST-Y study. This is a double-blind, placebo-controlled withdrawal trial in axial SPA patients on ixekizumab. The participants in this study had completed one of the 3 pivotal trials of ixekizumab, and during the lead-in period, they went on to either ixekizumab every 2 weeks or ixekizumab every 4 weeks. At week 24, for those who achieved remission at week 16 or week 20, they entered the withdrawal study. These patients were randomized to either a placebo group, meaning withdrawal, or remain on their current regimen. The primary outcome of the study was the proportion of flare-free patients at week 40 of the randomized withdrawal retreat period, and time to flare is a major secondary outcome. The main result is presented here. A total of 155 patients were entered the withdrawal retreat period, and 40 weeks later, about 83% of patients in the ixekizumab groups remained flare-free versus 55% in the placebo groups were flare-free. Continuing ixekizumab significantly decreased the time to flare comparing to placebo, with most patients remain flare-free for up to 20 weeks after ixekizumab withdrawal. The author also presents the results in radiographic versus non-radiographic patients. The percentage were similar. It is worth mentioning that for patients who were on placebo and had flare-up when they were treated with ixekizumab, 93% of patients regained ASAS low disease activity status, and 44% achieved ASAS inactive disease, although these observations were made based on a relatively small sample size. So the main take-home message is here, 83% versus 55% during the withdrawal period. But overall, knowing these numbers and discuss them with patients in clinical practice will help patients to make decisions when it comes to stop medication. The next trial is on patients with suspected non-radiographic Axial SPA. Although ASAS criteria for Axial SPA was not intended to be used for diagnosing the condition, by now it has been widely used in clinical practice, including the non-radiographic arm of the criteria. However, many patients diagnosed with non-radiographic Axial SPA in the clinical practice is different from those in most clinical trials, because almost all the clinical trials on non-radiographic Axial SPA has a prerequisite of a positive SI joint MRI or an elevated CRP to enter the study. So what about those patients with normal inflammatory markers and non-active MRI? In this study, the authors included patients with suspected non-radiographic Axial SPA, defined as inflammatory back pain by Kaelin criteria, HRA B27 positive with at least one SPA feature, or B27 negative with at least 2 SPA features. Of course, they have to fail NSAIDs and have had to have high disease activity by BASTI equal or more than 4. At baseline, noted that 13% of the participants had elevated CRP and 18% had positive MRI per ASAS criteria. So majority of these patients either had a normal CRP or negative MRI. These patients were randomized to placebo or etanercept for 16 weeks, and the primary endpoint was ASAS 20 at week 16. 80 patients were randomized, and 17% patients in the etanercept group and 11% in the placebo group achieved ASAS 20, and there were no significant difference. Although the study has its own limitations, it brought up an important question. For those patients who we believe that they have Axial SPA but do not have an elevated CRP or do not have an active MRI, what would be the next best step when they fail NSAIDs? The last but not the least, I will talk about the MAXIMIZE trial, the first biologic trial specifically focused on the axial symptoms in psoriatic arthritis. This is a double-blind randomized phase 3b trial in patients with psoriatic arthritis by axSpA criteria and at the same time has back pain, a visual analog score of 4 or higher, and BASDI of 4 or higher. A total of 498 patients were randomized to placebo group, secukinumab 300 mg every 4-week group, or secukinumab 150 mg every 4-week group. The primary endpoint was ASAS 20 at week 12. 63% patients on the 300 mg regimen and 66% on the 150 mg regimen achieved ASAS 20, comparing to 31% in the placebo group. Similarly, 44% on the 300 mg regimen and 39% on the 150 mg regimen achieved ASAS 40, compared to 8% in the placebo group. At week 52, more patients achieved ASAS 20 and ASAS 40. So the study demonstrated the efficacy of IL-17A inhibition in the axial symptoms of psoriatic arthritis. But I think the more important aspect of the study is it brought up discussion on the definition of axial psoriatic arthritis, and whether the axial psoriatic arthritis is similar or the same to axial SPA with psoriasis. And this brings to the end of my talk, and here is the list of the references. And thank you for your attention.
Thank you, Dr. Wang, for this excellent talk that reviewed new findings in axial spondyloarthritis. Our next speaker is Dr. Lihi Eder, who will be talking to us about sex and gender differences in spondyloarthritis. Dr. Eder is a clinician scientist and a rheumatologist at the Women's College Research Institute, an associate professor of medicine at the University of Toronto in Canada. Dr. Eder has a broad background in rheumatology with specific training and expertise in clinical epidemiology, imaging of psoriatic arthritis, and cardiovascular diseases in rheumatic patients. She is the director of the Psoriatic Arthritis program at Women's College Hospital and co-director of the Cardio-Rheumatology program at the University of Toronto. Dr. Eder was awarded the Canada Research Chair in Equity in Care of Rheumatic Diseases. Dr. Eder's research efforts have resulted in over 140 peer-reviewed publications in medical journals, book chapters, and editorials. As a recognized expert in rheumatology, she received a New Investigator Award from the Arthritis Society in 2016 and the Early Research Award from the Ontario Ministry of Research, Innovation and Science in 2018. We will now listen to Dr. Eder.
Hello, everyone. My name is Lihi Eder. I'm an Associate Professor of Medicine from the University of Toronto in Canada. And it's my pleasure to talk today about sex and gender in spondyloarthritis. These are my disclosures. So why study sex and gender? We talk a lot about personalized medicine and what is the right drug for the right patient. And both sex as a biological construct and gender as a factor that affects patient behavior have important influence on disease course as well as response to treatment. So by ignoring sex and gender in our analysis and in our assessment, we miss opportunities to identify factors that can help us select treatment or improve management of our patients. And there are several examples for this. For example, 80% of the prescription drugs withdrawn from the market pose greater risk for women than for men. Another recent example is that the FDA approved different doses. In fact, lower doses were approved for women for Zopiclone, which is a sleeping pill, after post-marketing studies identified that they cause harms and risk for women more than in men. So these are two examples outside of rheumatology that show us that a sex and gender-based analysis is really important in identifying a better way of using medications in our patients. So before starting to talk about sex and gender issues in spondyloarthritis, we need to understand what are the definitions of sex and gender, because these are often used interchangeably in medical literature, not always in the right place. Sex is a biologically based construct that defines differences between males and females. Sex is usually used as a binary variable, defined in studies as being a male or being a female, and it has important influence on biological processes such as gene inheritance and expression, pain perception and pain mechanisms, pharmacokinetics of drugs, as well as function of the immune system. Gender, on the other hand, is a sociocultural aspect that refers to being a man or a woman. It assesses the effects of social norms and expectations of men and women in a given society, and therefore it changes from one society to the other and during the course of history. It has important influence on the way patients behave, such as it can affect health-seeking behavior, risk-taking behavior, for example, smoking or drug use. Gender can also affect certain employments that women are more likely to select than men, and it will also affect gender relations and therefore influence support and coping mechanisms. Gender is much more difficult to evaluate because it has multiple domains, and it's not typically assessed in trials or in studies other than evaluating whether someone is a man or a woman, which misses a lot of the domains that are encompassed in this construct of gender. So let's talk about spondyloarthritis now that we understand the basic concepts. And sex distribution differs between the different diseases included in the spondyloarthritis. Ankylosing spondylitis is considered as a male predominant disease, and earlier studies found a female to male ratio of 1 to 10, but a more recent series identified a lower ratio of 1 to 3. And it's not really clear whether this difference is related, at least in the past, mostly to underdiagnosis of ankylosing spondylitis in females. Psoriatic arthritis and non-radiographic axial SpA are more equally distributed between men and women, and it's been hypothesized that perhaps women has less radiographic joint damage, but in terms of MRI findings, there is an equal distribution, and therefore the new ASAS definition that does not require radiographic damage to classify someone as non-radiographic SpA allows more women to be diagnosed as such. In terms of clinical presentation and impact of the disease, there's been quite a few studies in both PSA and ankylosing spondylitis. And overall, there are some consistent results showing that while men tend to have more severe radiographic damage, both in the axial and peripheral joints, women tend to report worse pain, worse function, quality of life. In addition, females tend to have more peripheral joint involvement than men. And these are some examples. One example from a cohort of patients with long-standing ankylosing spondylitis, and they described that in men there was more radiographic spinal damage with higher Basri scores that this difference remained significant after adjusting for age and disease duration, while in females there was more peripheral arthritis. Women were also more likely to be treated with sulfasalazine and prednisone, perhaps due to this peripheral joint involvement, and there was also worse function as indicated by higher BASFI and HAQ scores in females, and this is despite the fact that men had worse radiographic damage. Our group described differences between men and women with psoriatic arthritis. and we found first that there was an equal distribution of HLA-B27. We found that men had more radiographic axial involvement. They were more likely to have sacroiliitis in desmophytes, as well as joint damage in their peripheral joints. And oligoarthritis was the most common pattern of disease at the time of the presentation in men. In women, on the other hand, polyarthritis was the most common pattern at the time of presentation. Women were less likely to develop erosions, but yet despite the fact that they had less radiographic damage, women reported worse physical function, more fatigue, and worse quality of life. What about imaging findings? So this is ultrasound study that we've performed, and enthesitis is considered to be an important domain in PSA. We've looked at enthesial changes in men and women with PSA, and we found that men tended to have more enthesitis, both structural as well as inflammatory changes in ultrasound, and this was independent of age and BMI. However, it's not clear whether this is really a specific finding to PSA, because another study that looked at healthy individuals found similar differences between men and women in terms of structural and inflammatory changes at the entheses. And it's possible that these reflect differences in exposure to biomechanical stress or response to biomechanical stress between men and women. And it's been suggested that some of the differences in terms of the male to female ratio observed in ankylosing spondylitis may be due to delays in diagnosis in women. There is a meta-analysis that was published a few years ago that studied 42 studies. They did not find any differences in terms of the HLA-B27 prevalence, but they did find that women were more likely to experience delays in diagnosis that resulted in over 2 years longer delay from the onset of symptoms between men and women. Another study from Europe interviewed patients, and they found that women reported higher number of visits to their GP, physiotherapist, and osteopath during the time prior to the diagnosis, which reflects a longer journey that women had to experience until they were actually diagnosed as ankylosing spondylitis. And there are some potential causes for these delays. It's been shown that women were less likely to have radiographic damage, so by using only X-rays as the mean for diagnosis, women may experience these change less frequently or at a longer stage or delayed stage of their disease, and that this may explain some of these delays. Women also tend to present with more peripheral arthritis, and this may confuse the physician when considering the diagnosis. And also women tend to report more widespread pain. Up to 25% of the women reports widespread pain, which may lead to a diagnosis of fibromyalgia rather than ankylosing spondylitis. There are also some biases from the physician side where ankylosing spondylitis may be conceived more as a male disease, and therefore this diagnosis is less considered in females. And it's been shown that women with more predisposing factors, such as a family history of ankylosing spondylitis or anterior uveitis, are more likely to be diagnosed as ankylosing spondylitis than women without these factors. And this, again, may suggest that physicians may need more factors, objective factors, to consider this diagnosis in women. There are also some differences in the way the disease is expressed, or at least recorded, by males and females, and we use typically PASDAI or ASAS as outcome measures to assess disease activity in axial SpA. PASDAI, as you all know, is a questionnaire that includes 5 questions. And ASAS was developed to try to find a more objective and a better way of assessing disease activity in axial SpA. And it includes 3 of the questions that are part of BASDAI, but in addition, it also includes the patient global assessment and the CRP. It's been shown that BASDAI, this is a meta-analysis, BASDAI tend to be higher in women than in men, with a mean difference of more than 0.5 points higher in women, while there was no really difference in the scores reported by men and women, which, again, I'm not sure which one is best to be used, whether we should prefer one over the other when we assess men or women, but this is just reflecting the difference in the way patients report their symptoms. Now let's talk about treatment response in men and women with spondyloarthritis. And here we are mostly limited to observational studies because clinical trials typically don't report the results stratified by sex. And that's unfortunate because we, as mentioned at the beginning, we lose opportunities to try and look at differences in response, and some might differ across different classes of medications. So this is one study in ankylosing spondylitis that actually did use clinical trial data. They pulled data from 4 RCTs in AS that included patients using etanercept, sulfasalazine, or placebo. At the beginning, women tended to be older and had shorter disease duration and lower CRP levels. And from patient-reported outcomes, women started these studies at a worse point. They tended to report higher BASDAI, they had more back pain, and had higher patient global assessment. And while both genders showed an improvement in their scores, women were less likely to achieve desired endpoints such as ASDAS response and improvement. In addition, women were more likely to discontinue the medication early, either due to adverse effects or to inferior response. Another study, this is from PSA from Denmark, using the Danbio register. They evaluated patients who were using their first TNF inhibitor. Again, women started these treatments, were older, they had worse patient-reported outcomes, and more women had depression and anxiety. And similarly to the previous studies, fewer women achieved desired endpoint at 6 months, so 70% less likely to achieve outcomes such as the ACR20, ACR50. And again, 50% higher risk of discontinuing the drug early. So overall, we see, at least in these 2 studies, consistently that women are less likely to achieve optimal response in clinical trials, but it's really not clear whether this is a phenomenon that is unique to a specific class of drug, or whether we can see these across different classes of drugs. And in recent times, more trials are starting to report sex and gender effect, and we hopefully will be able to have more information regarding these differential responses. So let's talk now about mechanisms for sex disparities. And there are some differences in genetics. In ankylosing spondylitis, sporadic AS is more common in men, while familial AS is equally found in men and women. And it's been suggested that perhaps this is due to the fact that women with AS may require greater genetic load. But as I mentioned before, it's possible that there is also a bias in terms of diagnosis among physicians to diagnose women as AS, and they need more objective findings such as a family history to consider this in the differential diagnosis. In psoriatic arthritis, genomic imprinting was suggested as a potential mechanism. And genomic imprinting is an epigenetic effect that causes differentially expressed genes depending on the sex of the transmitting parent. And it's been shown that higher penetrance of PSA is observed if the father is affected by psoriatic arthritis, but it's really not clear exactly which genes are implicated in this. There's not a lot in terms of basic science or animal models looking at immune dysregulation in spondyloarthritis in terms of sex differences. And this is one recent study that showed that there are some differences in disease expression. They took mice and injected IL-23 mini circles, and they showed that female mice had more severe arthritis than male mice, and they didn't lose weight. And I thought it was interesting because it does show correlation with what we do see in the clinic. So it's possible that there are some biologic mechanisms that are responsible to these differences in clinical presentation. And we definitely need more studies looking into this. There are also potential differences in terms of pain mechanism, both biologics or sex-related mechanism and gender-related mechanisms. It's been consistently shown that women report more pain, and pain may affect quality of life, and all the patient-reported outcomes tend to be worse in women. This is not unique to spondyloarthritis. Pain scores tend to be higher in females across different rheumatic conditions, including in OA. And there are some suggested biologic mechanisms for this. Sex hormones influence pain threshold. And also there are some differences in the wiring of pain neurons and receptors in the brain. There are differences in the number of opioid receptors between men and women. So there are some biological differences here that might explain why women report more pain. But there are also some gender-related factors. Given the gender effect, women may be more inclined to report pain or report higher levels of pain. And there are also some differences in coping mechanisms between men and women that could also influence pain response. And finally, anxiety and depression, as you all know, are more common in women than in men, and these certainly have an effect on the way people experience pain. Now, in the final part of this talk, I'm going to discuss pregnancy in spondyloarthritis. And there are not a lot of studies, and these studies are relatively small, but all of these studies showed consistently that PSA follows a pregnancy pattern that is similar to that seen in rheumatoid arthritis, where there is an improvement in disease activity of both PSA and psoriasis during pregnancy, while during the postpartum period, studies have shown worsening of arthritis in women. In terms of adverse pregnancy outcomes, again, these are relatively small studies and not very good studies, but so they are limited in their ability to identify adverse effects. But it's been shown that there is a higher risk of preeclampsia, elective C-sections, and preterm birth in patients with with PSA. AS, on the other hand, or axial SpA, has a different course than that seen in RA and PSA, and women tend to experience similar degree or even worse degree of axial symptoms during pregnancy. There might be some improvement in peripheral arthritis experience as can be seen in PSA, and there is really no distinct pattern seen during postpartum period. In terms of adverse pregnancy outcomes, similarly, there is not a lot of studies, but some studies suggest higher risk of C-section in women with AS. And lastly, I'm going to discuss briefly some results from a recent studies that looked at MRI changes during the postpartum period. As we all know, bone marrow edema, as detected by MRI in the sacroiliac joints, can help us diagnose axial spondyloarthritis, and these have also been shown to be affected by biomechanical stress. So, for example, in people that are doing professional sports activities, there is a high risk of developing these lesions, and these can look exactly like the bone lesions that can be seen in AS and may confuse us. They are typically not accompanied by structural lesions such as erosions or fat infiltration though. So this study examined whether these changes can also appear during the postpartum period, and they recruited 35 women, and they evaluated them up to 10 days postpartum, and then at 6 months and 12 months. And they evaluated whether they had bone marrow edema in the sacroiliac joints, and they defined sacroiliitis based on the ASAS definition. And as you can see, most of the cohort had these changes in the sacroiliac joints during the immediate period postpartum, 60% of the patients. But importantly, these changes gradually resolved, and as you can see here, during 6 months and 12 months, fewer patients remained with these changes, although it's still important to keep in mind that slightly more than 10% of the patients did have these changes at 6 and 12 months. Importantly, there were mostly these inflammatory changes, but structural changes were rarely seen, so that can help differentiate, if needed, whether these are relevant and important for the diagnosis or not. And it's really important to keep in mind that during postpartum period, women can experience these changes, and it's probably better to delay performing an MRI in women postpartum if considering this in the differential diagnosis, because these findings are not rare. So I'm going to summarize. I've shown you some sex and gender-related differences between men and women with spondyloarthritis, and there are differences in the disease course, in presentation, as well as in response to treatments. We definitely need more studies to understand the mechanisms of these factors, whether these are biological mechanisms or whether these are gender-related mechanisms, or both. There are significant delays in the diagnosis of axial spondyloarthritis in general, but these are more consistently seen in women than in men. I talked about response to treatment, and we definitely need more information, particularly from clinical trials, reporting the results of these studies by sex, so we can understand whether these responses are seen across all modes of actions or are unique to one or several modes of actions. And finally, there are differences in the pattern of disease during pregnancy between axial SpA and PSA. We still have some gaps in knowledge. As I mentioned, we need to understand which biologic and sociocultural factors underlie these sex-related disparities. We also need to better understand the differential response to treatment. The effect of hormonal changes such as menopause is essentially unknown in PSA and SpA. And it's also important to understand how sex and gender intersects with other factors such as age, ethnicity, and race in spondyloarthritis. I wanted to thank Spartan for inviting me to talk, and thank you for your attention.
Discuss sex and gender differences in spondyloarthritis. Our next speaker is Dr. K. Geert Herman, who will be talking to us about low-dose CT in axial spondyloarthritis. Dr. Herman is a musculoskeletal radiologist and professor of radiology at Charité Medical School in Berlin, Germany. He is the head of Arthritis Imaging Research Group and the head of Berlin Case Viewer e-learning project. Dr. Herman is focused on the imaging of the arthritis, and the majority of his research projects are in the field of spondyloarthritis. He has also a strong track in applying innovative technology within medical education. He is an active member of the Assessment of Spondyloarthritis International Society, also known as ASAS, and has won multiple awards. We will now listen to Dr. Herman.
Ladies and gentlemen, my name is Kai Herman. I'm a radiologist from the Charité Hospital in Berlin, Germany. It's my pleasure to speak today about the use of low-dose computed tomography in axial spondyloarthritis. Thank you very much for inviting me. I have structured my lecture into 4 parts. I would like to speak a bit about the general use of CT, and I will also touch on dual energy CT. We will see how CT is used in the differential diagnosis, and I will also discuss some alternatives to CT in the diagnostic cascade of axial spondyloarthritis. As we review the EULAR recommendations for the use of imaging in the diagnosis of spondyloarthritis in clinical practice, we will learn that there is no place for CT in the general workup. There are 2 imaging modalities recommended, and these are conventional radiography and MRI. However, there's a small footnote where CT is mentioned, and CT is especially recommended to depict structural damage if there's no X-ray possible and if there is no option to perform an MRI. But we will learn that CT has its role also in the diagnostic workup on a routine basis in our general patients. So if we have a look on the workup of axial spondyloarthritis patients in the diagnostic routine, we will usually start with an X-ray image, and as the X-ray reveals clear chronic sarcoiditis, as in this example, there's no further imaging step needed to make the diagnosis. However, if there are X-ray images like this one, which is more or less normal, then usually as a second step, MRI is recommended. And as you can see, with the 2 sequences, T1 weighted MRI and STIR sequence, we are able to depict not only the active changes of the disease, but also the structural damage, which is sclerosis, fatty metaplasia, and ossal erosions. So where's the role for CT? CT usually is done today in a low-dose protocol. That means the high radiation exposure that we are used to apply years ago is no longer necessary, as we have now newer detectors, we have new reconstruction algorithms, and there's no need for high radiation exposure in our patients. Especially as we are only looking at the bone, and the bone is a very dense material and it gives a very good contrast compared to the other soft tissues. CT is a technique that is very fast. That means the patients have to be in the machine only for some minutes, and it allows for a very exact depiction of the bones, and we can even do three-dimensional reconstructions, as we are having very thin slices of usually 0.5 millimeters thickness. In our routine, we are using CT as a problem-solving modality if MRI is not helpful to make the diagnosis. Most of the time now also dual energy CT is performed, and I'm showing you some of the applications that can be done with dual energy CT. With dual energy CT, you acquire two separate X-ray photon energy spectra, and these different energy spectra lead to different attenuation of the materials at the different energies, and it's possible to calculate material decomposition images with the help of mathematical formula. As you can see here, this is a typical diagram of a dual energy CT spectrum. We have the high energy scale and we have the low energy scale, and we can see that based on the different attenuation values, we can distinguish between calcified tissue, which is the trabecular bone, and the cortical bone, and also other soft tissues, in this example uric acid deposits. Many different options are there to perform dual energy CT. So the oldest one is the use of two X-ray tubes and two detectors. That means we have a very high demand for the engineering team to bring these two tubes and two detectors into one machine and let them rotate around the patients. Now, also other vendors are having methods to acquire dual energy CT images, and most of them are using the fast switching between high voltage and low voltage scans within one rotation, as it is depicted here. You can also do it in a sequential fashion. That means you first do a circulation with a low energy tube, and then you do another circulation, and you have in between switched the tube current to a high energy status. And there's also newer detector generations where we have dual layers, and that means with the use of filters we have the acquisition of the two energy spectra in one detector. So at the end we are having two different scans, and we need to do the calculation in order to create the color-coded maps. Here you see one of the oldest examples of a dual energy CT. It's about 10 years old, and it was applied to search for gouty tophi at the ankle joint. As you can see, there is a green color here coding for urate deposition. But if you have a look at the CT images, you can see that there's a calcified soft tissue component, also the erosion, that can be seen, quite frankly, here on the CT scan, and there's no need for dual energy CT. We also used this technique in our patients in a population which was much less affected by gout, and you can see that here we had also the possibility to highlight the uric acid deposits in our patients, in this example on the big toe, and here in this example we also coded it in red. That means the color of the soft tissue deposits is dependent on the computer algorithm and the vendor, so there's no standardization of these color-coded maps. What else can be done with dual energy CT? We are using it frequently now also to have a look into the bone itself and to search for bone marrow edema. And this is done with the help of virtual non-calcium imaging, which is called UNC8 dual energy CT. And here you have one example. So this is an image which has calcium content a little bit removed. And if you compare the left and right joint, you might see that there's some high intensity signal on the right side. And this compares nicely with an MRI scan. As you see, the technique is still in its footsteps. However, the vendors are very enthusiastic about this option to show bone marrow edema with a computed tomography machine. We can also use this technique in the diagnosis of osteoporosis. Here you see an example where there's a fracture to be seen on the X-ray image over here, and there's a end plate fracture on the L4 vertebral body that is also visible on the CT scan. We performed a dual energy CT scan and calculated UNCA images, as you can see, there is some increase of signal in the L2 vertebral body that nicely compares also with the MRI. And going back to the CT image, we can see there's a slight fracture here in the anterior edge of this vertebral body that could be addressed by our orthopedic surgeons. Next option that we have with virtual non-calcium dual energy CT is the collagen emphasized imaging. So we have collagen imaging available, and here you see an example of a normal spine, as you can see, and there's a CT scan which shows the dense vertebral bodies and the intervertebral disc as a area with lower density. UNCA images depict very high signal inside these intervertebral discs that is equivalent to the collagen contents of these discs. For comparison, also the normal MRI STIR and T1 images. Using this technique for a patient after a trauma, there you could see that this is a patient with dish syndrome, and there was some fracture of the vertebral body over here, and you can see the normal intervertebral disc in the adjacent vertebral bodies, but you can reveal also there's low signal intensity in these two intervertebral discs, and that means that these discs might be injured and need to be addressed also during surgery. Comparing this with the STIR images, and you can see there is hematoma-like signal inside the nucleus pulposus that is a sign of injury. Usually the MRI is not performed in the acute setting, so having this information available based on the CT is a thing that our surgeons are very likely to use. How can we use CT in axial spondyloarthritis? Here's a patient with advanced axial spondyloarthritis, and you can see that there are end plate erosions at the lower lumbar spine, but there are also some sclerotic areas in the thoracolumbar junction, and at the same time there is also fatty metaplasia at the corners of the vertebral body and also inflammation. So how do we use CT in these circumstances? So if we focus on this upper segment over here, there is edema-like change in the STIR sequence, so there is active inflammation still there. At the same time, we already see high signal intensity in the T1 weighted scan, which means there must be some sort of fatty metaplasia. And comparing this to the CT scan, we can see that it's in fact already dense bone. So we have in the same segment dense bone, fatty metaplasia and edema, and we might need to use these two options, MRI and CT, together in order to really appreciate the full spectrum of the disease in patients with axial spondyloarthritis. Coming back to the sacroiliac joint and revealing some of the anatomical variants and mechanical disorders at the disease. Here we have a 49-year-old woman which is EB25 positive, and she complains about inflammatory back pain. Looking at the upper row, we can see there is high signal intensity in the iliac bone and also a little bit in the sacral bone. So we could mistake it for active sacroiliitis, but at the same time you see it's very much located at the posterior aspect of the joint and also near the joint capsule. Comparing it with the T1 weighted image, we see that the cartilaginous joint, which you can see over here, is no longer visible in this slice, and in the next slides even you see the interosseous space with the fatty components of the interosseous ligaments, and there's an attachment of the iliac bone to the sacral bone over here, and we were not sure about it, so we performed first an X-ray image, which was not very helpful at this moment, and also a CT, so we could see there is an accessory joint facet that is creating this mechanical mechanical blockage of the joint, and therefore it creates this osteoarthritis-like change in the sacroiliac joint. So CT was very helpful in this particular patient. It is of note that the sacroiliac joint has a broad variety of shapes, and few is known about these different shapes. Here's an overview that was performed by my colleague Katharina Ziegler, and you can see that the normal shape of the sacroiliac joint is only visible in about 80% of the patient. We see posterior joint facets. We have the iliosacral complex, which is like an interlinkage between the iliac bone and the sacral bone, and very many mechanical complications can arise from this kind of anomaly. We also can see there's an example with a deep groove of the iliac bone over here. We have the crescent shape sacroiliac joint over here, and we sometimes also see small isolated ossicles at the joint. So this is especially to be seen with computer tomography of the sacroiliac joint. Sometimes these anomalies in shape are difficult to distinguish on the MRI scan. These differences in the shape of the sacroiliac joint, they are also relevant in terms of interpretation of the complaints of the patient. As you see here, there was a patient with very severe complaints at both sacroiliac joints, and you can see that there's an iliosacral complex with interlinking of the iliac bone into the sacral bone, and there was severe bone edema due to this anomaly, and we did not diagnose this as an sacroiliitis in terms of axial spondyloarthritis. Another example over here, where we had a young patient with pain at the cervical spine, and even the rotation of the head was very difficult to perform, and we saw a lot of inflammation at the lateral facet joint over here, and it was not clear what the reason is for this pain. We performed the CT, and we could see the nidus here in this osteoid osteoma of the second vertebral body. So in terms of structural damage, most of our focus lies in the detection of erosions. We are having possible options to see the erosions in the CT scan, as you see here. However, if the CT is not an option for you or your patients, you can also perform MRI in order to search for the erosions that might not be readily visible on the T1 weighted scan. So you need advanced imaging techniques like the susceptibility weighted imaging, so-called SWI imaging, and you see here this looks like a CT image, and you also nicely see the erosions that are depicted over here, but this is an MRI image and can be done without radiation exposure. Similarly, the wipe sequence is an MRI technique that is able to depict erosions at a far better quality compared to a T1 weighted image. You see here that is a T1 weighted image on the MRI. We see one erosion, maybe a second one, and maybe some smaller one over here. And if you compare it with the wipe sequence, we have a very high contrast of the cartilage compared to the neighboring bone, and we see many small erosions over here, which becomes especially evident if you are looking at the full 3D data set. And the wipe sequence is a three-dimensional sequence where we can see small erosions due to the low slice thickness, and we can also do three-dimensional reconstructions of these scans. Also, nuclear medicine provides very nice alternative techniques compared to CT. Here we have a SPECT CT, which is in combination of functional data with morphological data. This is a patient with axial spondyloarthritis and very active bilateral sacroiliitis. As you can see, there is no erosion yet visible on this CT scan, but there's very high active bone metabolism, so it's also very compatible with axial spondyloarthritis. I would like to come to the end of my presentation and would like to summarize. I think there's a role for all the imaging modalities in the diagnostic workup of patients with suspected axial spondyloarthritis. I think X-ray and MRI are by far the most widely used techniques, and this is for good reason. There is nowadays debate if the X-ray images is still something that should be performed. I think there are many differential diagnoses that can be seen on an X-ray image that are difficult to distinguish on an MRI scan. So I would recommend continuing to use X-ray. CT is usually done after MRI and after X-ray, and as such it is a problem-solving tool and sometimes also is needed for the planning of surgical procedures, but it's more or less a problem-solving tool in our institution. And I also highlighted some of the newer techniques like SWI imaging or wipe sequence in order to enhance the use of MRI in patients with suspected axial spondyloarthritis. I hope you could learn a little bit about CT and what we radiologists make out of it. I highlighted some of the newer techniques like bone marrow imaging, which will more and more be available in the radiological departments worldwide. Thank you very much for your attention.
Thank you, Dr. Herman, for this excellent talk that discussed low-dose CT in axial spondyloarthritis. Thank you, everyone, for attending the 2021 Post-ACR Spartan Grappa ASAS Symposium. We hope that this has helped you stay up to date in the growing field of spondyloarthritis. Please remember that in order to receive CME credits for attending this educational activity, you will need to complete the survey that is posted in the chat box. These past 2 years have been very difficult and challenging with the pandemic, but we hope that the pandemic will end soon and that we will be able to meet in person for the next symposium. We wish you all the best. Please stay safe.